Oh, we're just past the top of the hour. I am just going to stand in for our moderator, and I want to welcome you all to our Alberta Transplant Institute seminar series. My name is Sean Delaney. I'm fairly new to ATI, but I think a number of you do know me from my past work and even patient history. Just start off with some pre-business issues. I'd like to first start with the land acknowledgement. The University of Alberta acknowledges that we are located on Treaty 6 territory, and we respect the histories, languages, and cultures of all of the First Nations, Métis, Inuit, and First Peoples of Canada, whose presence continue to enrich our vibrant community to this day. We want to thank Paladin for their support of our ATR seminar series. I'd like to give a very warm welcome to our speaker, Jordan Wadden. He is a full-time bioethicist and in the ethics department lead at Ontario Shores Centre for Mental Health Sciences. He also facilitates a regional ethics hub, which consists of additional hospitals, rural health centres, children's centres, and community mental health organizations in the Central East region of Ontario. His approach prioritizes the inclusion of patient and family voices and emphasizes the clinical decision-making benefits of being comfortably uncomfortable. I love that. As a researcher and advocate, Jordan's work focuses on equitable access to healthcare and health services, disability advocacy, and the implementation of artificial intelligence and machine learning in hospitals. He is currently wrapping up a PhD at the University of British Columbia, where he focused on the patient's ability to consent and the clinician's obligations when employing powerful artificial intelligence in diagnostics. He has a master's in philosophy from the Toronto Metropolitan University. Please welcome Jordan and speaking on exploring the ethical considerations of direct contact in pediatric organ transplantation. Thank you, Jordan. Welcome.
Yeah, thank you for having me. And I actually have as I'm loading up the slides, a nice little update on that bio. It's no longer completing a PhD, it is completed a PhD. That just happened 2 weeks ago.
Congratulations, that's awesome.
Thank you. Yeah, so as Sean was saying, I'm going to be talking about the ethical considerations of direct contact in pediatric organ transplantation. On the screen, you can see my research team. Most of us are from British Columbia. That's where this study took place. And it might seem a little odd that someone from Ontario was leading this, this study. It's because as I was doing the coordination, the setting up of interviews, the conducting of interviews, I was employed at PHSA, the Provincial Health Services Authority. And then when I was doing the analysis, I had actually gotten a job out here in Ontario. So that's why it might look a little weird. I have no conflicts of interest to declare, and I'm not going to be talking about any off-label use of drugs or devices, so there's no worry about that. Before I myself get started, I also want to do a land acknowledgement, just because this project took place outside of Alberta, and also I'm coming to you from outside of Alberta. So it's important to also recognize the lands where this project happened, where I'm currently located, because that does affect how we approach equitable healthcare and how we approach reconciliation. So I'm joining you from the lands of the Mississaugas of Scugog Island First Nations, which are under the Williams Treaties. The Mississaugas are a branch of the Greater Anishinaabeg Nation, which includes the Algonquin, Ojibwe, Ottawa, and Potawatomi. My co-authors, as well as PHSA, BC Transplant, all of the institutions that were involved in this study are situated on the traditional, ancestral, and unceded territory of the Squamish, Stola, Tsleil-Waututh, and Musqueam people. You and our many study participants, some who ranged all the way into Quebec, despite being centered in BC, may reside on these lands, may reside on the lands that were already acknowledged earlier, or may reside somewhere else not listed. As for funding, we could not have accomplished this project without the help of the Transplant Research Foundation of BC. We received a 2021 TRFBC venture grant to do this work. And while today I'm going to be giving kind of the overview of the work and some of the implications of the work, if you want to see the full report, it is actually now available. That has also come out since I wrote that bio to give to ATI. This has now been published in the American Journal of Empirical Bioethics. And that one goes into a much more detail than what I'm going to have the time to go into today if you wanted to get any of that additional information. Okay, with that out of the way, let's start diving in. The outline for today's talk is that I'm going to go through a bit of the background. So why are we even focusing on direct contact? What is direct contact? For many of you, that might be a new term. Then I'm going to outline the methods of our study, how it was that we conducted it, why we chose certain things. I'm going to discuss the results, and for those results, I'm going to be focusing on the on quotes from the participants themselves. I feel like if we're going to be talking about what the impact of direct contact might be, it is important to hear it from them rather than from some academics or university scholars or hospital ethicists kind of saying what we think it means. You're going to see names in that results section. These names are pseudonyms. When we were doing this research, we gave each of the participants the opportunity to name themselves so that they were still connected to the results. And when we gave them the reports after the fact, they would be able to find out how they directly impacted the study, while still protecting their privacy, because we made sure that their pseudonyms were also significantly different from their real names. So when you see names, please don't freak out. We did take that into consideration. And then I'm going to end with a discussion just of what these results mean and kind of where BC is hoping to move to in the future. So with direct contact, we first want to look at what it looks like for adults. In anonymous correspondence programs, they exist in many years across many different provinces, countries, geographic regions. Direct contact is non-anonymous correspondence. And this can be anything from exchanging emails so that you can actually contact that way, all the way up to a full facilitated in-person meeting with the individual. Direct contact of this sort was established in adults in BC back in November 2019. And there were there's some kind of requirements. We'll get to those on the next slide. But as I was saying, these can be independent, these can be facilitated, these can include just an exchange of names all the way up to in-person meetings. And it was really created in response to self-advocacy from donor families and transplant recipients. No one group led more than the other. They both kind of collaboratively came to BC Transplant and said, this is what we want, to be able to finish grieving, to be able to move on with our lives, to be able to accept the gift that we received. There's 3 criteria to be able to enroll in this direct contact. The donor family and the recipient must have exchanged anonymous correspondence at least once. A minimum of 12 months needs to have passed since the date of the transplant to mitigate any kind of snap judgments or emotion or emotionally driven responses, good or bad. And BC Transplant must have received initial independent requests for direct contact from both the donor family and the recipient. That way, they're sure that no one is being pressured into this because, oh, one person said that they would like it, so the other person just kind of acquiesced. They have to be independently received. This is done through a match with a social worker. Most of that is done through Jordy Hermiston, who is one of the co-authors on this study. And he will support the donor family and the transplant recipient through a consent process where you discuss the expectations, hopes, fears, boundaries, strengths, and support systems that need to be in place for this to work. He helps them co-create a direct contact plan that feels comfortable for all involved. Sometimes the transplant family wants to just exchange names, but the recipient family really wants to meet in person. Well, where do we meet? Do we just end it at the names? Is the transplant family willing to do more? They were just worried about harm. We'll get to that actually in the results. And And then the last thing that he does is he helps them release the consented identifying information between the donor family and the transplant recipients. So there's some numbers about the transplants. So in 2021, 41% of donor families had received or sent anonymous correspondence. And the numbers fluctuate a little bit. 2021, mainly the numbers were going down because of the COVID pandemic. Being in transplant, this is probably nothing new to anyone who's on this call today, but the risk of COVID infection is just so much greater for these populations that more people were kind of hesitant to reach out, even anonymously so. Now, to date, BC Transplant has supported 12 donor families and transplant recipient pairs through this direct contact process. 23 donor families or transplant recipients have expressed interest in writing, but without the same request coming from their counterpart. Again, going to show that it has to be two different independent requests. Now, this is great that we have it in the adult context now, and we've had it now for going on 3.5 years. But why conduct this research for the pediatric side? Well, adults are assumed to have capacity to make decisions unless otherwise indicated. Children and adolescents, however, are in the process of developing capacity. And depending on which province you're in, they may or may not have capacity. So it's going to be really hard to navigate that, especially in the context of transplant, where the recipient might be from Alberta coming into BC or vice versa, or as one of our donor families, they were all the way from Quebec. So you're crossing these borders, which have different laws and legislations around who is capable to consent for things. So children and adolescents in this context, do they have the capacity to consent for direct contact? Should the SDMs be able to decide in this context? Because it's not really a healthcare decision, it's more of a social decision. And why or why not should that actually have some sort of impact? We know that anytime children and adolescents are involved, there's a different type of ethical analysis that needs to be done. So some of the risks that arise from children and adolescents is just elevated vulnerability. Not only are these transplant recipients, these are also adolescent transplant recipients. So they're doubly kind of vulnerable. There's the heightened impact of family dynamics. Are we sure that a kid is going to be comfortable disagreeing with their parents? Perhaps they want the direct contact, but their parents don't. What's that going to look like? And then there's also the various legal protections. However, the benefits of creating such a program, we would be empowering choice. We would be helping children and adolescents exercise their autonomy muscle. We also, in so doing and empowering that, we're respecting them as individuals, as persons, rather than saying you're a non-person until you have capacity. And ultimately, we're avoiding paternalism, which is something that the medical field has been trying, unsuccessfully, but trying to move away from since the 80s or so. Now, another reason to conduct this research that we did is that nothing in the literature directly discusses this topic for children and adolescents. If ever it's mentioned, it's offhanded or it's in a common popular media article. There's one website, transplantfamilies.org, that believes contact assists at some points. So our goal was to really try to help examine this ethical landscape about the direct question of direct contact for children and adolescents to actually have an answer as to whether this should occur. And this is important because just as in the adult setting where it was self-advocated, it's being self-advocated in the pediatric setting and the adolescent setting. Now, we only have data from the adults, but donor families often feel uninvolved or unsupported following a donation, which can be especially difficult if they find that they have a bond between them and the recipient, either metaphysical or literally physical, because it's a loved one's organ that's now been gifted. But recipients themselves also experience psychological and physical distress in the process, and not from the transplant. It can arise because of conflicting guilt and gratitude. They got to survive because someone else had to die. Or there's also the oddities of something called incorporation, where now they've taken someone else into themselves. That someone else is now a part of their identity. So they're also experiencing some turmoils that don't necessarily always get talked about, even in the adult setting. And despite all of this, organizations have felt the burden to enforce anonymity due to risks of harm, which is why we're worried about paternalism as one of our main questions. And this is especially true if there's a perceived imbalance in the relationship, which in donation there is. The person receiving an organ can never really repay the person who gave the organ, because it, especially in the context that we did this study, which was deceased donors, someone died. So our study questions, and then I'll move on to the methods. What are the harms and benefits of allowing or preventing a direct contact program for the pediatric and adolescent population? Is it appropriate to have parents act as substitute decision makers? And does this structure influence whether donor families are going to be comfortable to participate? Is restricting direct contact to only adult families going to be an issue of fairness? And then finally, if this was to go through, what supports would need to be in place for people to feel like they could participate? So moving on to the methods. Potential participants were identified by an internal patient record search at BC Children's and BC Transplant. They were recruited based on 3 different categories. So we had recipients who had received an organ as a child but are now adults, and we included their families. Recipients who received an organ as a child and they're still a child, and their families. And then the third one was family members of a deceased organ donor. Didn't have to be someone who donated directly to a child, and we chose that specifically so that we wouldn't accidentally cause any sort of identification. So we just took any organ donor, or organ donor family, I should say. And the study had 2 phases. We did the donor families and current adult recipients because they were more removed, they'd be able to kind of reflect, and we used their responses to temper how we asked the questions, though we still asked the same questions. In phase 2, which was for more donor families, and then current pediatric recipients, those who were still children. And our youngest who we interviewed was 7 or 8. Regardless, still very young. We did a semi-structured narrative interview through the spring and summer of 2021. Semi-structured just means that there were some questions, but we weren't just kind of blitzing through them. We were using the question more as a guide, and sometimes didn't necessarily read the question verbatim because it was more about, did we cover this discussion topic? And narrative just means we're focusing on the story of the individuals rather than trying to hyperfixate on some piece of information. They were conducted on Zoom, again, because of the vulnerabilities of COVID. We wanted to make sure that people felt comfortable participating. So we made sure, since this was an extra vulnerable group, that we were only going to be meeting virtually. Some of the interviews were as short as 27 minutes. The longest one was 83 minutes. And from the interviewer perspective, from my perspective, I was asking questions in a naive and collaborative way. So I was making sure that I didn't make any assumptions. I let them tell their story, and I let them guide the discussion. I might have had the questions, but they were the ones who were leading this discussion. And it mitigated the fact that the participant pool in BC is quite small, and the naive approach meant that we could reach saturation, which is a qualitative methods term for having enough data that you're starting to see repeats in the data. And that's really hard, especially with a small cohort like is the pediatric population in BC. So that's part of why we wanted them to be leading the discussion, so we could make sure we captured everything and actually reach that saturation. And we used a combination of deductive and inductive codes. Deductive codes just mean that we had the idea already of how to classify our data, and inductive means we allowed the data to speak to us to create new ones. So we used a combination so that we wouldn't be making any assumptions. Here's the interview guide. I won't go through each individual question, but I just want to highlight that we focused on context development to build a rapport with our participants and to understand, what does it mean to be a recipient or to be a donor family member? We then moved to the details and opinions, where we focused explicitly on the direct contact question. And then we ended with community needs. So if this kind of program was created, what supports would you need? If this program was created, what is an appropriate time to be told about it? And then this was the big question, just what about the experience of being a donor family member or a recipient? Do people not know enough about, and do people not talk about, that perhaps could help us guide our analysis or guide future studies and future researchers in this field? Oh, and I should say, these questions were heavily influenced by our patient and family partners. So two of our co-authors, Ranjit Dhaliwal and Shelby Geelan, they themselves are a donor family member and a organ recipient, respectively. So Ranjit is the mother of a deceased organ donor, and Shelby herself is a organ recipient. And we included them not just as consultants, because this was ultimately about their communities. We included them as full authors, and they helped us guide these questions. They helped us guide the analysis. They called us out on some of our own assumptions. They were really key for this study moving forward. So the sample characteristics, or the people that we actually had participate: 29 participants across 20 different in-depth interview sessions. We had 18 women and girls, 11 men and boys. No one identified as non-binary. We had 7 potential participants lost to contact, and 15 potential participants declined, mostly from the donor family. And we found out after the fact, because we tried to do a little follow-up just to ask them if they were comfortable sharing why they didn't want to participate. And they said that they thought that we had reached out to them in error because their loved one was an adult. So we lost out on some commentary due to just the intricacies of trying not to identify the donors with the recipients in the process of our research. Pediatric recipients who had aged into the adult program and their families, we had 13 of them. Those still in the pediatric program, we had 11, and the family members of deceased organ donors, we had 5. 5 seems very small, but we did actually reach saturation where they started to repeat the same information to us that each other had said. We looked at 3 main organ groups. So for the kidney recipients, we had 3 adults and 6 adolescents or children. For heart, we had 4 adults and 2 adolescents. And for liver, we had 3 adults and 6 adolescents. And you can see that we actually had a lot more on the adolescent side who agreed to interview. And we interviewed some pretty young kids. So let's go into the results. Again, I just want to re-highlight that you're going to see names here. These are pseudonyms. The pseudonyms were chosen by the participants, but they do not identify the participants. So I'll have these quotes on screen that you can read, and I'll just kind of talk through what each of these sections meant while you're reading those. So virtually all that could remember, as well as the parents of those who could not, reported that the process of becoming a transplant family was marked with increased sense of either responsibility, worry, protectionist or perfectionist thinking. However, all of them reported that becoming a transplant recipient or a donor family member engendered just an overwhelming sense of gratitude. Of the 5 donor families who participated, all expressed that becoming a donor family was meaningful to them and their loved ones, frequently using words like silver lining to describe their ability to donate and to gift those organs. All of them expressed that donation was unquestionably aligned with their loved ones' values. And now all of the families, both recipient and donors, expressed experiencing difficult emotions throughout their journey, regardless of how long it had been. Frequently used words here included impacted me for the rest of my life. I know that's not a word, that's more of a phrase. They also used things like roller coaster, draining, shock, cried a lot. And several from both groups just said that the feeling was really inexpressible. There was no word or phrase that they could give us. Now, from a sense of wondering, this is where we're starting to get into the direct contact, the connections. 19 participants explained that they had already wondered about their donor, their donor's family, or their loved one's organ recipient, while 7 expressed never wondering and 3 didn't answer the phrasing of this question. Of those who wondered, 16 were recipients, while 3 were donor family members. Common questions included how old the person was, what their health was like prior to transplant or donation, what their health was like after transplant or donation. Well, not really after donation, that's more of what the health of the family member was like, I apologize. Most frequently though, the main question was whether the other individual, be it the family member of the donor or the recipient themselves, just knew how much that donation was appreciated if they were a recipient, or whether the other individual's life had improved the donor families. 15 expressed wanting the program to exist for themselves, while 4 said that they wanted the program to exist, but not so much for them. They probably wouldn't choose it, and 6 expressed no interest in the program. And that's not a negative interest, that was just, they were neutral. 11 of the recipients, 11 of the recipient participants, however, and this is pretty interesting, had either already met their donor family, 5 of them, or had learned significant personal identifying information, another 6. These families expressed dissatisfaction with the medical system's limitations, explaining that they understood why most clinicians were just looking out for their safety, quote unquote, but that these families explained this was something they felt they had to do. They had to know. Among those who learned information but did not meet their donor family, 5 received the information through accidental direct disclosure by a hospital staff member, while 1 received the information through actively contacting transplant societies. Now, on the harms and benefits, beginning with the harms, only 5 participants expressed that they thought direct contact would result in some personal discomfort or more significant harm. 4 said that they were unsure or too far removed to be certain, and 13 expressed quite explicitly that they saw no potential for harm. Harms referenced by those participants included being overwhelmed emotionally, having different backgrounds or core beliefs than the person, and that affecting their experience of the transplant process, or that the other family's trauma might just bleed into their own traumas and potentially re-traumatize. Now, surprisingly, despite only being asked about their personal harms, 14 participants, so more participants, expressed that they were more worried about potentially harming the other person, the other recipient or donor family, through their own desire to meet. Now, regarding the benefits, 23 indicated that they believe direct contact would have helped their recovery or their grieving process, including all 4 donor families who chose to respond to this question. Benefits referenced included being able to get closure, being able to express gratitude, being able to contextualize their own experience, and knowing that their loved one's gift was well received. Now, again, despite not being asked about the benefits to others, 20 participants, including all 4 donor families who responded to the question, expressed beliefs that this could be more beneficial for the family they're connected to through donation, rather than the benefits to themselves. Several expressed that while they might personally benefit, the main reason they wanted to have direct contact was to provide that benefit to the other family. This slide's a bit boring. There's not really any good quotes for policy, so I'll just actually have notes on this one. So regarding the policy, we elicited 2 different responses, 2 different main tensions, I should say, from the participants. The first one was whether or not it would be appropriate for the parent to consent, which was a question that we had initially proposed. And then the other one was an interesting development. At what age could a youth make the decision for themselves? Again, in different provinces, there's different capacity regulations. Where I am in Ontario right now, everyone is capable unless proven otherwise. It's pretty easy to prove that a newborn is not capable, but it's really difficult to prove that a 12-year-old isn't. Whereas in BC, we have something called the Infants Act. So anyone under 19 is technically not able to consent for themselves unless they're a mature minor, unless they're an emancipated minor, unless they're the parent of another minor. There's a bunch of different considerations, but for the most part, they need a parent to consent. So like, where does this bar go? Where do we put this ability to consent? From the participants, the children, the family members, and the donor families, there was no clear consensus about whether a parent should be the one consenting, mainly because direct contact is non-medical. And while not being medical, it does still have medical and psychosocial implications. So people were really confused by that, like confused about what they should themselves believe. Now, on the age of consent, parents of recipients, all ages, the adult recipients as well as the current recipients, indicated that they thought their child would be capable of consenting around 14 to 16 years of age. The youth and the adults who were recipients themselves said that they could probably have consented to this between 9 and 12 years old. And this included like I said, this included the adults who were children when they were transplanted, but are now in the adult system. Even they consistently still said between 9 and 12. So it shows that there is some sort of continuity of what age the individual themselves thinks is appropriate. So finally, before I move on to the discussion, what does the community need? Well, there were the three most common requested supports were psychologists and counselors before the meeting, social workers both before and after the meeting, and mediators for during the meeting. Other supports included family meetings, mentorship from those who have already met their donors or met their recipient family, information packets, financial aid, and the recipient families are the ones who brought up the financial aid, and they are the ones who were also the most vocal about saying all the time financial aid goes to recipient families and it's never advertised for donor families, and they saw that as a problem. And they, quite a few of them, made it very clear that they wanted me, if I was ever to talk about this, to talk about that. And this is coming from the recipients saying that the donors don't get financial need. So they're very intertwined, much more than a lot of the hospital folks seem to think, but probably just as much as many of you on this call already know personally. Additionally, recipient families strongly believe that any supports, not just the financial, should go to the donor families. And almost all participants who responded to these questions indicated that families should be told about the possibility for direct contact in the general information package before transplant. And then also as part of the information discussions immediately after transplant, with a few saying that, maybe we could wait until shortly after transplant. But the majority opinion seemed to be, tell us multiple times. You tell us about the risks, you tell us about the benefits of the transplant, you tell us the risks and the benefits of the donations psychologically on those who are still living after the deceased donor is able to give the gifts. But you never, why would you separate this out as something different? You tell us multiple times about other things, tell us multiple times about this thing. Regarding the interval of time to wait before actually having a meeting, responses ranged from immediately while people are still in the hospital, all the way up to 1 year with no clear front runner. Accompanying this was the frequent clarification, but depends on individual recovery. And from the adult model in BC, it seems that 1 year is an appropriate amount of time. So that is likely what would happen moving forward. And finally, participants were asked what they wished more people knew about being involved in organ donation and transplant. And while there were many, many thoughts that emerged, one of the big ones that emerged was that transplant recipients are just like any other person, that transplants are not cures, and that being a donor family really does give your family a sense of peace or purpose when your loved one passes. They also, both groups, wanted to highlight that transplant research has been negligent in including lived experiences in the past, focusing more so on the biomarkers or on the new surgery techniques, and not so much on what happens in the years after. And that they were really wanting more of these studies to happen, especially in the pediatric focused lens, because a lot of people will focus on the adults first. So what does this all mean? There is a distinct desire among transplant communities in BC for direct contact programs. This appears to exist for both recipients, their families, and donor families, without one group being less or more invested. We also know from this that while clinicians, ethicists, and policymakers might worry about the harms outweighing the benefits, the opposite may in fact be true. While pre-study discussions with clinicians indicated a belief that the harms outweighed these benefits, participants themselves indicated the opposite. Most participants from these three groups expressed more benefits than harms, and many only discussed benefits, saying that harms were really just in reference to whether or not their own desire would harm someone else, rather than this interaction having harm for themselves, which was the main question and the main worry from these clinical pre-study discussions. The main benefits that recipients assumed donors would experience were closure, with well over half of the respondents making this assumption. And this matched the most common self-reported perceived benefit from donors, who said that we would want closure from this. The main benefit that donor families assumed of the recipients was a little harder to pin down. All who answered the question said that it was probably going to be a miscellaneous benefit that they would experience without specifics, kind of a more nebulous thought. And while you might think it's hard to connect that to an actual response from the recipient family, ironically, the majority of the recipient and their families said that their most commonly believed perceived benefit would be a nebulous, unsure benefit that they couldn't quite pin down. So again, this is showing that these two communities are so much more connected than researchers and healthcare workers tend to think. And because of this, we need to recognize that both recipients and donors seem to know more than clinicians and researchers assume about their own recipient or donor connection, about their own situations, about how to find information, about even who each other are. They explicitly recognize that much of the research in transplantation is primarily focused on physical health, as I was mentioning a few seconds ago, without equal attention to the mental or social health benefits or risks or harms. And this is important to highlight because it directly and explicitly demonstrates how patients and their groups often know more about what is their overall best interest than outsiders. This is a term that comes from Harvey Carroll, who is a philosopher of illness. So outsiders are those who themselves have not experienced a condition, and they can make assumptions. They can be trying their best. The majority of healthcare providers are outsiders. It's the insiders who know their overall benefit. The outsiders just know their medical benefit. So this is something that, along with the responses from our participants and then our analysis afterwards, we really want to highlight is that there is this tension between this first personal and this third personal recognition of what the harms and benefits are to a social program and to social research in transplant. And recognizing this difference in perspectives can help healthcare providers avoid slipping into paternalistic restrictions by believing that they're upholding a patient's best interests, when we as healthcare workers might not actually know what those best interests are. So we need to more carefully walk the line between protectionism, where we protect the patient by promoting their desires, and paternalism, where we protect the patient, quote unquote, by limiting their desires due to risk. The development of a pediatric direct contact program, we believe, is justified based on the identified expressed desire, based on the comments that we've got from the BC community, and importantly, also based on the comments as well as the changing legislation depending on when you cross a provincial border. Such pediatric programs must be consent-driven, and that consent must be on the pediatric recipient and not on their parent or guardian. The clear differences in attitudes surrounding consent, paired with the fact that recipients necessarily must be involved in direct contact, indicates that these youths ought to be the central decision makers. This isn't to say that parents and guardians should be removed. They should absolutely be there to help guide a informed choice, but that informed choice should be on the recipient and the donor family, because they are the two that are now connected by the donation. And while this might seem like it pushes consent too far, again, there are several models in Canada that allow for adolescents to consent to their own treatments. While in BC, there's the Infants Act. In Ontario, there's the Healthcare Consent Act that says everyone is capable unless proven otherwise. So this is not going to be something out of the blue. This is not going to be strange. Now, this might not be enough to convince some people that a direct contact program is actually a good program. So another way to kind of justify this, as our last slide, and then I'll open it up for kind of discussion, such a program could be also developed from a harm reduction perspective, given how many participants have already made contact with their donor families or their recipient, the organ recipient, or just have located significant identifying information through informal means such as news reports or social media. Again, of our 29 participants, 11 had already found information. Harm reduction approaches are sometimes difficult to get stakeholder buy-in for, as the more risk-averse stakeholders might interpret them as recommendations advocating for harm to their patients. But this approach, what harm reduction really means is that you are trying to mitigate the harm, not by preventing the action, but by putting supports around the action so that it is more safe. It's normally seen in illicit substances, but it has been moving into other fields more recently. And we think that it would work pretty well on this regard as well. The direct contact program could achieve this for pediatric patients by allowing their recipients and their donors, not patients, by allowing for information exchange in a controlled and mediated environment, rather than through random chance in online forums, or through databases, or through approaching someone that you see leaving a hospital and saying, "Hey, did your loved one just die?" These happen. These hit stories across country borders, and this is what gets focused on in the news. So if we could put a harm reduction lens on this, where, okay, we know that these families need this for whatever reason, whether or not we agree they need this, how do we make it safe to access that information? Well, by allowing a direct contact program. So where this is going right now in BC is that BC Transplant is putting together a working group to try to move for a pediatric and adolescent direct contact program. There's nothing formal yet. They're still in discussions, but that's kind of what the goal of this research was, is if it came out positive, we were going to try to create a program. If it came out negative, we were going to try to create policy against such a program. We were really trying to build this research around what the community actually wants and actually needs, rather than trying to guess and see if we got it right. So I'll put the references slide up there just for the, I know this is being recorded for YouTube, so just for a little bit so that people can pause. And then I will stop sharing and we can open for discussion.
Thank you so much, Jordan. That was an excellent presentation. Even though I did kick off the presentation, I was not the formal moderator. Ms. Michelle Hsu, a pediatric transplant coordinator here in AHS and Edmonton, is actually going to take over the Q&A with a much more expertise than I will demonstrate. But I would have a first question. I think it was great that you talked about talking at the very beginning with donor families about the potential for direct contact. I think there's also that other side of, is there a need to also talk about, if you're going to go down the road of direct contact, you may need to be prepared that A, not every organ was ultimately donatable, and B, not every organ that got donated is still in a living recipient. So that, there's a few other, issues to consider in there, and is that way too early in the process during the donation to even have that conversation? Just a planted idea.
Yeah, and that was one of the worries that our pre-study clinical encounters kind of brought up, is that we know that there's rejection rates. We know that after a certain number of years, some organs just kind of automatically fail. So what does that do to the donor family who might be hoping for some good news and to make a connection? We did actually have this come up with some of our donor families, and what they were saying is that, look, we're not stupid. We know that there are these rejection rates. We're told about that. Just knowing that someone got a few extra days is still good enough for us to want to make that connection to fulfill that grieving process, to help them fulfill their recovery process. So even they were recognizing it.
Yes, excellent. Thank you.
Thanks so much, Jordan. This is really interesting and definitely will be affecting all of our patients as you guys move forward. I do have a quick question before we move on to the general questions. And that's just if you guys thought much around some of the non-accidental childhood trauma and those donors where it could have been a family member who is the cause of death. Did you guys kind of think about that at all?
So no, we didn't. We tried to stay away from some of the tougher topics in donation, not because we wanted to avoid that discussion, but because we were still so early in since there's no literature already, we didn't want to kind of start off on those kinds of more detailed topics. We wanted to have it available for people to then riff off of. And perhaps someone at BC Transplant or someone at ATI will be the ones to then go down that route of what does it look like in this specific setting. We kind of hope that we were opening that door rather than closing it.
Fantastic, thank you. I do have a question here from the comments, and the question is from Heather. Sorry if I'm saying your last name wrong, Badenoch. Did you want to speak, or did you want me to read it out?
No, I'm happy to speak.
Perfect.
Jordan, a massive thank you for doing this research for a couple of us on the call anyway, who are, and I'll keep this brief, but living non-directed donors. This is an issue that we discuss a lot and have on our own advocated to our transplant center, who used to have a 1-letter limitation rule to be allowed to, yes. So in any event, we advocated at length. It took 3-4 years, but they agreed that we'd be allowed to exchange more than 1 letter anonymously with our recipients. My question is simply around expectations. And so did the recipients express what their expectations were? And I realize that it would be different for everyone, but was there any trends around just simply knowing who their donor was and their age and some things that you talked about? Was there any discussion about, you sometimes hear like we're family now and we're going to spend the holidays together. Were there trends in what you heard?
Not really trends. They were, as you were suggesting, kind of all over the place. Okay. I will say though, of those 11 who already had information and then kind of skittering down, of the 5 who had already met, they were kind of speaking about that. 2 of them were saying that, like, yeah, we're family, it's great. And then one of them was saying, the donor family has made us family, great. So it was kind of mixed opinions, even among those who are discussing about those kinds of connections, even when they're both on the recipient side.
Hey, interesting. Which I guess to your point is why the facilitated process makes so much sense.
And that's what, for the adults, what Jordy does is part of that process, before he even lets you start to talk with each other, is what are your expectations? And if your expectations do not match the other party's expectations, we're gonna navigate this until they do.
Thank you. Thank you.
Of course.
Anne, I think you've got your camera on there. Do you have a question as well? Oops. Oh, you just muted yourself.
My computer's slow here. I think Simon was ahead of me. I was going to ask about basically something similar to Heather's. So I think Simon should go first.
Doesn't matter. You can go ahead.
No, I'm good.
Okay. Okay. Thank you, Jordan. That's a really interesting insight that you're providing there. The one thing I'm missing, and I think Michelle touched a bit on that as well, is you mentioned that there is presumed harm and that it was maybe a paternalistic approach and things like that. But reality is also your group that you have asked about does not have the insight into the background, as Michelle mentioned. So where did these organs come from? What was the lifestyle of the person? How is that going to affect the teenager who's probably in a vulnerable position at that time themselves? What are they interpreting? I've been doing pediatric heart transplant now for almost 20 years, and I've heard very, very surprising feelings that our recipients sometimes express about what they think about their donor or how it may have affected them and things like that. And then on the same side, we've experienced breaches of confidentiality where we then heard that actually for the donor family, it was like losing their child again. What if the recipient starts, smoking drugs instead of taking their meds and loses that organ, that precious gift that they have received? So it's a highly emotional situation. The situation it currently is here is we actually encourage our families to write to the donor family anonymously. It goes through the HOPE coordinators, and it is made sure that there is no direct information. And after a time period, I believe it's 2 years in Alberta, they are allowed to have contact with each other, direct contact. So I was wondering, because it sounded to me a bit like what you're aiming for is a encouragement project rather than an offer of direct contact. I find the system as it works here is pretty reasonable because it gives people to get out of the highly emotional time, while you'll never get out of this sentiment of gratitude and guilt and all those things probably. So it still becomes so how would you suggest also to navigate that if you have a situation where you feel there may be sinister motives, for example, of a donor family, or there may be who would be the person to then decide who can be in contact and who cannot?
Right. So the idea would be to create something that's very similar to what BC Transplant already does for the adults. So there would be a facilitator, someone at BC Transplant, the family services social worker, likely Jordy, who would be receiving these independent requests for contact. And then if both kind of parties do initiate that request, then he'd be going through them. What is your motives? Why are you wanting to do this? I didn't talk about it much because the focus of the presentation was on the pediatrics and on our research, but there's an extensive process to go through for the adults to be able to actually get to the point of discussing expectations. And the idea would be to have something very similar for the pediatrics as well. Because again, as I kind of pointed out at the beginning, they're kind of more vulnerable. They're not just organ recipients, they're also organ recipients and children who don't have fully developed frontal cortexes and whatnot, don't have fully developed abilities for reasoning for the most part. They're pretty scary when they do have like that one topic or those two topics that they do have on lock. So the idea wouldn't be to create this as like a encouragement project. I might have been talking about it that way because I was trying to reflect the emotions and the statements that the participants themselves were conveying. And by nature of this kind of research, the people who agree to participate are likely going to be a smaller group than the total group. And they're also going to be probably representative of those who actually show interest in the end, rather than necessarily representative of the whole group. So they were the ones who were kind of advocating for this, self-advocating. We decided to take this on as a research project to see if it was possible, rather than something to kind of, okay, you're transplanted 1 year, you're automatically into the direct contact. I hope that answers your question, Simon.
We just have a few minutes left, so let's plan for Anne and then Deanna. It looks like you've also got your camera on.
Mine was really more just a quick comment. This is really great study. I really enjoyed your presentation, and I don't think you talked about living donation, but I'm just wondering if the same kind of approach could be taken to think about living. It's quite hard in Canada for living donors to be connected with recipients, and a lot of the same questions, and it could be specifically to pediatrics, but really anybody. And I just think the approach was so thorough, and I think it would be really interesting to think about it from that side too.
Yeah, for sure. And at the beginning, we considered also including living donors. We chose not for exclusionary reasons, but because the program that we would be if this was to be something desired, the program we'd be modeling it after the adult program was also only for deceased donor. So we tried to kind of rein it in to make it a more doable project with the opportunity for other groups or ourselves to kind of move on further afterwards. Yeah, but we did discuss it. I do want you to know we did discuss it.
Go ahead, Deanna.
Hi, Jordan. Thank you so much for a great talk. I just had a question. You'd mentioned, capturing lived experiences of these interactions, and wondering if you had any future plans for, patients and donor families who have this opportunity to meet and go through this experience, to maybe perform like another qualitative study from maybe like a phenomenological lens of capturing, the difference. Like there's, the desire to have these interactions, but then there's also like, what is the actual experience for each of these sides, and kind of from their own perspective in that lived experience, what it felt like, or what it as it's happening.
Yeah. So I think that's something that would be led by Jordy's team, by Tom Blight-Hansen's team. He's the director for the multi-organ transplant at BC Children's. And it would have to be after kind of the program is kind of created, because we'd want to make sure that the responses were actually informed by those interactions. It's something I might actually propose to Jordy for the adult program, because we're only 3.5 years into that, to kind of see that phenomenological side. So not an answer directly to your question, but definitely giving me room to think about something else.
Great. Thank you so much.
Yeah. I'm not afraid of phenomenological approaches, just to be clear. I unfortunately have my PhD in philosophy rather than in clinical, even though I'm working in the clinic myself. So phenomenology is just kind of, it's there. It's on my desk.
There was one last question in the comments that just mentioned, I also wonder about the desire for a donor family to have anonymity when the death of their loved ones was from suicide or overdose. How would these situations be handled?
Yeah, so if a family decides that they want to remain anonymous, then, all they have to do is not ask for direct contact. So very early in the presentation, I went over the numbers for who has reached out but has not had their partner also reach out. So there's about 23 families as of like October, November of 2022 who they've expressed interest, but the corresponding individual has not expressed interest in meeting. And if a family wants to remain anonymous, they just have to continue exchanging anonymous correspondence, or to just stop exchanging correspondence whenever it is right for them to stop. And there'll be no kind of pressure to get them into a direct contact situation, because it needs to be independently from both. And that's part of the reason why that safeguard is there, so that there's no pressure on a individual to, oh, the donor really wants to meet, so I guess I'll say yes. We want to avoid that.
Perfect. Yeah, that definitely answers that. And I guess that's similar to when we have the anonymous letters going back and forth. If a family doesn't feel like they're ready to read it, then we just hold on to it until they are, right? So
exactly.
Perfect. Well, this was fantastic and definitely opens up a lot of questions and answers a lot as well. I really enjoyed this talk, and I hope we hear some more about this program as you guys move forward.
That's the hope. Yeah. I'm a little
Thank
bit
you.
isolated now being out in Ontario instead of in BC, so I don't necessarily have the most up-to-date information myself.
Fair enough. Fair enough. Well, thank you very much, Jordan.
course.
I think it sounds like we've got all of the questions answered. So I guess since it's 1 o'clock, we will sign off.
Get all the
All
links.
right.
Thank you, everybody. Have a
Thank
great
you,
week.
everyone.
Bye.
Thank you, Jordan.
Thank you so much.